What's up, Gestalt Education Nation? Today's episode is brought to you by The Payday Practice and our good friends Jeff Langmaid and Jason Deach.
So how would Seth Gooden, Gary Vee, and Tim Ferriss create a chiropractic practice? The answer is in this book right here. So our good friends Jeff Langmaid and Jason Deach, they created the Payday Practice to basically show you how you cover your monthly expenses in one day every month. Guaranteed. Generating monthly recurring revenue in your practice can create financial freedom, eliminate chronic financial stress, and turn the first day of each month from damn, it's time to start over to payday.
Get a free copy today at www.thepaydaypractice.com. The Payday Practice will show you the exact step-by-step process that you can use to generate monthly recurring revenue in your practice. Get your free copy today at www.thepaydaypractice.com.
All right, everyone. Welcome to another episode of the Gestalt Education Show. Today, we are in beautiful Pittsburgh. My first time in Pittsburgh, actually. So what a pleasure to be here, Brett. And so we're sitting down with the one, the only Dr. Michael Schneider. And so, Mike, you are a professor in the physical therapy department here at the University of Pittsburgh. You're also one of the founding members or founders of the Primary Spine Practioner program. You're a research nerd, as we've kind of discussed earlier in before we kind of went on air. And then you got some absolute... What do you got here? Knowledge geek. There you go. Okay. All right.
Now it's official.
Knowledge geek. Okay. And then you're kind of a pioneer in this world of chiropractic to have some pretty high ambitions that we were talking about that we're going to get into today. So, talk to us about how the heck do you wind up at the University of Pittsburgh and especially in the physical therapy department?
Yeah. Well. I'll make a very long story relatively short. I'm from New Jersey originally, so if you're picking up an accent, that's what that's from. But I've been in Pittsburgh since 1990. Moved here mainly for family reasons. But I don't know, I was always interested, even when I was in practice, I was always interested in sort of scholarly pursuits, if you will. I published articles in Dynamic Chiropractic magazine
Sure.
and wrote a couple case reports and things. So I always kind of had that academic bend to me. But being in Pittsburgh allowed me the opportunity to, use the medical library here to get articles. So I started meeting people at the university. And when my kids were in high school getting ready for that empty nest, I was kind of a late bloomer. I decided I was going to go back to school, get a PhD in rehabilitation science here at the University of Pittsburgh. So I did that and got my first NIH grant. And that got me a job at the University of Pittsburgh. And I've been here for about, on faculty, 12 or 13 years now.
It's pretty amazing. And then what was that? What was your, talk to us about kind of that transition from getting your PhD and then into this position. You're talking about that NHI grant is basically what gives you your salary. So then what was that first grant? And then what have you kind of progressed through from there?
Yeah, so actually it was interesting for my PhD dissertation project. I happened to be in an unusual position where while I was a PhD student, because I was a chiropractor, that made me eligible to submit an NIH grant. So I submitted my grant while I was still a PhD student, which is kind of unheard of. So I got funded while I was still a student. And so I ran a trial comparing manual manipulation with activator for low back pain. And we had a medical care group as a comparison group. So that was my first trial. And how did I wind up in the Department of Physical Therapy? Well, there's no chiropractic program at the University of Pittsburgh.
Yeah.
And they needed a place to put me, so they kind of just put me in the Department of Physical Therapy.
Yeah.
And it was actually a very good fit for me. And we could talk about that a little bit, the integration of a chiropractor into a Department of Physical Therapy.
Right. Well, and you kind of led me into my next question, which is there was no Department of Chiropractic at the University of Pittsburgh, and I said yet. So there's been rumors out there, and some inklings that maybe you're working on a little bit of a chiropractic program here. Can you give us an update on that? Is it true? Is it going to happen?
Yes. The long story, again, made very short, is yes. They're not rumors. It's true. I have submitted a proposal for a new Department of Chiropractic that would be separate from the Department of Physical Therapy. So we would be starting a new department in the School of Health and Rehabilitation Sciences at the University of Pittsburgh. A formal proposal has been put in. COVID knocked us back a couple of years. Now that we're post-COVID, the proposal's back in the approval process, and I'm hoping that within the next year it will be fully approved.
What does that look like, Mike, for a potential student? So versus like a private institution or university where everybody's kind of used to previously in chiropractic versus this would be more of like a public situation. So what are the big differences be between those two, do you think?
Yeah, I don't know if from a curriculum perspective and CCE accreditation, it's going to look that much different on paper. I think the big difference here is that everybody can recognize the how could I put this? The publicity that this will and the credibility this will bring to the profession, right? This will be the first time that there's a chiropractic degree offered at a major public university, right? The University of Pittsburgh's got 35,000 students. This is also a research-intensive university, right? We're always in the top 10 funding in NIH nationally. So the credibility that this program will bring to the profession is just huge. In fact, I attend the World Federation of Chiropractic meetings every 2 years, and all eyes will be on Pittsburgh internationally. I mean, I've talked to people at the schools in Australia, in Europe, in Brazil. Everybody's going to be looking like, why has this not happened in the U.S.? And if you think about it, chiropractic is expanding much more rapidly outside the U.S. than within the U.S. New schools are opening up all over the place. 2 or 3 new university-based programs have just opened up in the UK in the past 3 years. And we don't even have one in the United States yet. So this is very big news for the profession.
Now, in certain universities, as far as the chiropractic colleges go, some people think it's a little bit antiquated. So I'd be a little bit hard-pressed to think that you're going to roll out an exact curriculum of what we've seen in the past, especially with the PSP program that you've created here. So I'm assuming there'd be hints of that program that you'd be trying to implement into the curriculum.
Yes, I think that the focus of the program at University of Pittsburgh will clearly be on spine and musculoskeletal conditions. That's going to be our focus. We are not here to promote the primary care physician alternative model of chiropractic. Not to say that if chiropractors want to be doing functional medicine or treating non-musculoskeletal conditions, they're certainly welcome to do that. That's not going to be our focus here. So we're going to be very clear on that. We want our graduates to be excellent spine practitioners and also other musculoskeletal conditions. And I think a big part of our training is going to be focused on interprofessional, team-based care. One of the challenges that chiropractors have all over the world is having this lone wolf kind of practice where you're out there on your own trying to treat everybody by yourself. That's just not the model for spine-related conditions or musculoskeletal conditions, especially chronic conditions, right? As our population ages and we have more chronic back and extremity pain, we need more than one professional to take care of these patients. And we're going to teach our chiropractic students how to work as members of a team, not how to just be on their own. And I think this is something that has to change here in the 21st century. Chiropractors have to be working with other professionals, not just on their own.
Were you guys worried about it all when you named the PSP program? Obviously, you have spine in the name. You're not excluding extremities, but I think the argument I've heard is that chiropractors need to do a better job of owning the spine first. Like, the world needs to know that we are the experts at treating the spine, and then we can talk about these other things later. Is that the goal of the program, would you say?
Well, so we're now conflating the PSP program and the DC programs.
Yeah.
And we can talk about the Primary Spine Practioner program maybe separately. As far as the chiropractic program is concerned, as I was bringing this proposal here at the University of Pittsburgh, as you can imagine, people in all the other departments, for example, physical therapy, are saying, hey, wait a second, you're going to be competing with us. So what makes your program so different? So here's my elevator pitch, right? We're a School of Health and Rehab Sciences. We offer an occupational therapy degree. we offer an athletic training degree, we offer a physical therapy degree. What's the difference between those 3 degrees? Well, as physical therapists, we deal, mainly with orthopedic, musculoskeletal conditions. OT has sort of specialized in upper extremity, inpatient kind of stuff. And athletic trainers, they're doing more training and dealing with athletes. So I said, there you go. So there's overlap between all those 3 programs, but you've kind of got your niches.
Sure.
Chiropractic, we do spine.
It's perfect.
Notice how I'm not saying anything else?
Yeah.
Usually when I'm at chiropractic schools, asking students, well, what's your elevator pitch about chiropractic? And it's, well, we got the nervous system, we do this, blah, 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 blah. I just use one word, we do spine. Why can't you just stop right there? Because nobody in the healthcare professions does non-surgical, non-pharmacological spine care. Chiropractors do. So if we focus on that niche, that's how I sold the program here at University of Pittsburgh. We're going to focus on spine. Yeah, we're going to have overlap with musculoskeletal. We'll have overlap with athletic training. Yes, we'll have overlap, but our niche is spine-related disorders.
Gotcha.
Right? And the Primary Spine Practioner program is along the same lines, right? Where we have to, if you want to differentiate yourself as a chiropractor being great at spine, then that PSP certificate further defines you and differentiates you from your peers.
Yeah.
Let's take a deep dive into the PSP program. There's 4 modules, is that right?
Yes.
Yeah, okay. Can we kind of go through each module, what they encompass, the overall systems or approaches you're including in the program?
Right. Well, first of all, a couple foundational concepts here. The Primary Spine Practitioner is a certificate that's issued by the University of Pittsburgh. It's not a degree. It's not a diplomate like we have in our chiropractic world, but it's a certificate. It's considered a graduate level certificate from the University of Pittsburgh. It's offered to both physical therapists and chiropractors, which was kind of controversial. Why is this being offered to both professions? Well, again, because both professions have people who want to focus on spine. Not all chiropractors want to focus on spine, which is interesting to me, especially when I see them wearing ties with spines on it and spine rings and spine necklaces, and yet they say, I don't want to be limited to the spine. Well, then why are you wearing a spine around your neck? But I digress. There's certainly a segment of the physical therapy profession that really wants to differentiate themselves from their peers as doing spine. And they're a minority, right? They're a minority. Not most physical therapists want to do spine, but some do. And so as a University of Pittsburgh, we're not going to play favorites with degrees. So that's why it was offered to both professions. It consists of 4 units, as we call them. And a unit is a combination of online distance learning and a 3-day live course. So pre-COVID, those were 4 live courses here at the University of Pittsburgh. And we're going back to those live courses. For the past 2 years, we've had to do it all virtually. So between the online distance learning and the 4 3-day weekends, it's probably about a total of about 150 to 200 hours of instruction. All right? The first unit is about the overview of spine care and the biopsychosocial model. And we actually have 2 psychologists that have helped us with that, develop that unit, where we bring in the principles of motivational interviewing, cognitive behavioral therapy, interpersonal communication skills, how to talk to patients, and blending that in with guideline-based care. The second unit is all about the lumbar spine. Third unit is all about cervical spine. And the 4th unit is about bringing it all together in clinical team-based care with focus on chronic conditions, how to work with other professionals, including surgeons and interventionalists, and again, the team-based approach. So that's a bird's eye view of the 4 units.
And then within these courses, what are some, I think from talking to you, MDT's part of it, and then what are some of the other systems that you guys are trying to implement in the 4 modules?
Well, yeah, before we were formally recording, we were talking about this a little bit, right? That one of the challenges, I think, of chiropractic and physical therapy practice is people learn these techniques and systems, and they kind of try to pigeonhole their patient into a system, right? So I've taken all the McKenzie courses, mechanical diagnosis therapy. It's a great system. It's not for everybody, right? I've taken the neurodynamics, Shacklock course. It was excellent, but not everybody needs neuromobilization, right? When I was a chiropractic student, I went through the Motion Palpation Institute and learned all that work. I've taken Cox's work. So you learn all these different tools, and you have a toolbox, but there's very few programs that teach you how to use that toolbox. That's what we're trying to do with this PSP program. We're not trying to promote any particular one technique system. We're trying to show you, as an advanced spine practitioner, when to use what tool with what type of patient. So all of those are on the table in both of our cervical and lumbar courses. And we're trying to blend the best of physical therapy with the best of chiropractic and put them together for the benefit of the patient.
And how many people have you had run through your program so far?
Well, we've been doing the program about 5 years right now. I think we've had about 300 people go through the program.
Awesome. Wow, that's great. It's really great. Is the hope then that those people will get plugged into multidisciplinary clinics in big areas? What's like in a perfect world, what would be the best student to go through there? Or is it just even anybody in private practice?
Well, I think most of the people who've gone through our program, let's talk about on the chiropractic side for a moment, right? On the chiropractic side, the people who are going through it are looking to work in an interprofessional setting. And several of our instructors are already working in interprofessional team-based settings. So for chiropractors, the goal would be to get this PSP certificate and use that to leverage themselves into a job in an interprofessional setting. That could be the VA, it could be a large multidisciplinary rehab kind of setting. On the physical therapy side, what we're finding is that there are physical therapists who really want to own and excel at spine care, and even though they're already in an interprofessional setting, their setting doesn't have a designated spine-related PT, and so this allows them to differentiate themselves in that way.
Beautiful. And then what role does manipulation play in the primary spine practitioner? Where does it kind of where is there an emphasis on it? Is there not? Are you just assuming that people already understand the manipulation piece, or where does that all play in?
Yeah, so it's not just manipulation. I could say the same about, let's say, neuromobilization or soft tissue technique, etc. We don't teach any of these techniques in the course. People should be coming with that skill already, so we don't emphasize spinal manipulation any more than any other treatment intervention. It's on the table when we talk about when it's appropriate, but it's not the primary focus of that program.
So you're not teaching people how to manipulate in these courses. It's more about like this would be a time when you could use it type situation.
Correct. The same thing, we talk about the McKenzie system with directional preference and a repeated movement exam. We review those concepts, but we're not trying to compete with the McKenzie Institute. In fact, we, for example, highly recommend that everybody, whether they be PT or Chiro, go through the McKenzie courses because it makes them a better practitioner. I would say the same thing about manipulation. Most chiropractors, by virtue of graduating from chiropractic school, feel pretty skillful at manipulation. Physical therapists who want to learn more about manipulation, we don't teach that. That's up to them to go take those courses.
Sure.
Right? Same thing with neuromobilization. Mm-hmm. We highly recommend it. We review the concepts, but if you're not comfortable with your skill level, we go take a course.
Sure.
Right? So we're not in the skill building of manual therapy or exercise. We're trying to bring it all together. That this is an advanced course for people who already have those foundational skills. Beautiful. Just want to know how to integrate it into a package.
Sure.
In these rehab circles, Mike, there's a thought in the next 10 to 20 years that basically a chiropractor, a physical therapist, and a lot of people are including the ATCs in this group, are basically morphing into the same person. Do you think that's good, one, and is that the future that you see also, or what do you think? Or do you almost like see a divide in the profession where you do have that, but then you still have some of the old school chiropractors who are still thinking the same way they are now?
Yeah, that's a couple questions. Why don't you ask them one at a time?
Is it a good thing? Are you threatened at all by physical therapists learning from other chiropractors how to manipulate? And we'll put the ATCs in that same category.
Yeah, so I think, I don't know if it's good or bad.
Because the easy answer is yes. But then, like, if you talk to some of the big hitters in our profession over wine and behind the scenes, there's always a different story. So I'm just curious, like, what you truly think and what that all means, I guess. And then maybe it doesn't mean anything.
I wouldn't categorize it as a good or a bad thing. I just think it's inevitable. It's happening.
Right.
Whether we like it or not,
yeah, exactly.
It is happening. There's huge overlap between PT and chiro. Huge. And I think in our primary spine practitioner course, you talked about how, what happens in the back, when you go out for dinner and have a couple drinks with people and what's said over dinner and drinks versus what is said in public, right? So during our live courses here pre-COVID, I would always rent out a little bar and grill, and we would all go there after the course on Saturday night. And I remember one night, it's like midnight, and we're all hanging around.
Oh, it's getting good now.
We're all hanging out. Maybe it was 1 in the morning. I don't know. It's pretty late.
So it was 4 a.m.
It wasn't that late. They closed at 2 in Pittsburgh, so it had to be before 2 a.m. But it was pretty late, and everybody's feeling pretty good. And I remember talking to some people and they said to each other, I'll make up some names. Let's say it's Jim and John. Hey, Jim, I forget, are you PT or chiro? And I started realizing the lines were blurred when we were there at dinner because everybody thought the same way. And I'm like, wow, this is really interesting, right? We have PTs and chiros in the same room. They don't even know who's who because they think so similarly. So is that a good or bad thing? It's inevitable. It's going to happen. And I don't think anybody feels threatened by it because, frankly, although chiropractors say they're great at spine, I don't think that's true. I think that chiropractic education is not only focused on spine. We have so many other things in the curriculum that the average chiropractor is really not excellent at spine care, and certainly not the average physical therapist. So I don't know where it's going, frankly. Is there going to be overlap? Yes, there's going to be overlap. Could there be some new degree that comes out or some dual degree program?
Kind of a contemporary chiropractor, maybe?
Yeah, I mean, I like to think of ourselves as doctors of musculoskeletal medicine. See, to me, this is what's missing in healthcare all over the world, is we have, maybe I'm digressing here a little bit, but to answer your question, it's a bigger question. It's not PT, chiro, ATC. Let's talk about primary care. The model of healthcare is I have a pain in my body. I'm going to go to this generalist, the primary care physician. And this generalist is going to figure out what's wrong with me. No, they're not. That generalist is trained in internal medicine. They have no training in musculoskeletal medicine. So what really needs to happen is that patients walk into this generalist clinic and there are internal medicine triage people and there are musculoskeletal medicine triage people. And those musculoskeletal medicine triage people right now would be best served by PTs and chiros. And that's what we're trying to do with this PSP program, was it's not just spine, to your point, we need people who understand mechanical reasoning, musculoskeletal medicine. It's a different way of looking at patients than internal medicine. And this is why we have such a messed up healthcare system, is that you have non-musculoskeletal trained people diagnosing musculoskeletal problems. And they're messing it up left and right. So that has to change. And is there going to be competition? There aren't enough physical therapists or chiropractors to fill that role. So no, there's no competition there. I don't feel threatened at all by this association between PTs and chiros.
And would there be any fear, kind of how the osteopathic profession got swallowed up into, we'll call it allopathic medicine, whatever you want to call it? Is there any fear that as this blend occurs, that the chiropractor, like what we knew the chiropractor to be as we all went to school, that kind of goes away? That's no fear of yours.
That's not a fear of mine, but so what's going to go away? Be more specific.
Well, let me give you an example. The present day osteopath, we have a DO school in Kirksville. Actually, Andrew still started, like literally 2 hours away from where we're from. The present day osteopath graduating literally is not going to even lay their hands on a patient. They're not going to manipulate. I understand there's still a program at Michigan State that's teaching that. 30 years ago, my primary care physician that we went to, he could deliver a baby, he could adjust, this guy could do everything. He could do minor surgery.
Osteopathic physician.
Right.
Right.
So I think some people, to play devil's advocate, they fear that if chiropractic were to get swallowed up by this, like that we've kind of lost what we fought hard to get to this point. I'm not saying I 100% believe this thought. I'm just throwing that out there for you to answer.
Well, so what I'm trying to get you to say is, what are we giving up? What are we afraid to lose? What makes us so unique? To me, it's we're getting back to, I'm going to make chiropractic great again. How's that? Right? I mean,
that's your campaign.
That's my campaign slogan. No, but seriously, I mean, I went to Palmer. Palmer was all about the spine is the cause of disease. Look to the spine. Look to the spine. So, if our heritage is the spine, why don't we get back to that and really own it? I mean, the osteopaths became wannabe internal medicine docs, and the faction of our profession that wants us to be alternative primary care physicians, those kind of people would get swallowed up into the medical care. But being focused on spine and musculoskeletal, how would we get gobbled up into the medical model? We would not. And I'm a strong proponent of staying non-pharmacological. I don't think we need to be prescribing medicine, frankly. I think we need to know about it. So if we stay non-pharmacological, non-surgical, and we do spine and musculoskeletal, that's a huge niche. What are we getting gobbled up into? If anything, I would flip that and say that my experience as a chiropractor working in a physical therapy department is that they look up to us, right? We've been able to be so successful in spine care world. So do you know what percentage of the general population, when they have an acute episode of back pain, who do they see first? 40% will see a primary care physician, 40% will see a chiropractor. Guess what that percentage is for physical therapy first? It's like 7%. It's never gone over 10%. And that's,
they don't have portal of entry, though.
They do.
Not in Missouri, they don't.
In almost in 37, the majority of states, PTs have what's called direct access, and they fought really hard for that. And they thought that getting direct access would make a difference. It doesn't, because there's many reasons for this, and physical therapists will debate it, but most physical therapy leaders I've talked to say that they have a credibility issue with the public, cultural authority, right? The average patient in the United States doesn't see a physical therapist as, quote, a doctor to go see first for their condition. Chiropractors have that cultural authority as doctors of the spine. And the PTs say, wow, can we take a play out of the chiropractic playbook? They've been so successful. They look up to us. We were the original non-pharmacological alternative to spine pain, right? So are we going to lose that? No, we're going to bring that value, that philosophy into healthcare. We're not going to lose it. We're going to bring it with us, in my opinion.
Well, then at UPitt, would there potentially in the future be a blending of the physical therapy program with the chiropractic program? Because a lot of these courses are going to be very similar, I would think.
Yeah, well, I don't know, to be honest with you. I think, so for example, this has already started in our School of Health and Rehabilitation Sciences. We have an anatomy course, and this makes sense, right? If you take anatomy, it doesn't matter if you're a physical therapist, occupational therapist, or physician assistant, you all take the same anatomy class. because it doesn't matter, right? And I've already been told that the chiropractic program, our students will take that anatomy course. And so I think there are a lot of courses, like neuroscience, for example. Do I have to have a separate neuroscience course for the chiropractors than I do for the physical therapists? Probably not. So is there going to be some blending there down the road? Probably. I see a cross-pollination. I see our chiropractic instructors teaching in some of the other programs like physical therapy. We have a physician assistant program also. It'd be nice for them to learn a little bit about musculoskeletal medicine, don't you think? Instead of 0, which they get right now.
Sure.
Yeah, so this is a huge value having a chiropractic program in a university setting where we get to see the perspectives of the other professions.
Right. Yeah, I'm proud of you. I mean, it sounds amazing. Have you had pushback? Is anybody, like, to your face giving you pushback or not really?
No, not really. And it's been interesting. I've met with all the department chairs of physical therapy, occupational therapy, physician assistant programs. They all recognize when I say we're focused on spine, I mean, what's there to argue with, right?
Universal language, yeah. How can you argue with that?
Yeah, so no, I've not had any pushback. And including, I've spoken to, and we haven't gotten to this area yet, research, right? So the fact that I do research at the University of Pittsburgh and I've interfaced with people from all these other departments in the research world has given me a level of credibility that you just can't get without being in the trenches like I am. So for example, and we could talk about this, we just got a huge mechanistic research grant from NIH, almost $20 million grant, right, that I'm a co-investigator on. There are 30 of us co-investigators here at the University of Pittsburgh that as a team got that big grant.
Wow.
And that includes the chairman of the Department of Physical Medicine and Rehab. We've got the chair of pain medicine on that grant. We've got people from physical therapy, from psychiatry, from all these other departments. So when I was meeting with them for like 2 years to write that one grant, and when we got it, we all had a big party together, right? And we all know each other. So after 15 years of working with all these people, when Mike Schneider says, hey, Department Chair of Pain Medicine, can I get a letter of support for this chiro program here? Yeah, sure. Hey, Department Chair of Orthopedics, can I get a letter of support from you for this chiropractic program? Yeah, if you're running it, I'd be comfortable with that. So not only have I not had pushback, there's been actually enthusiasm about it, right? This is the year 2022, right? This isn't, 1922, right? Chiropractic's come a long way. It's mainstreamed now. So no, there's no pushback.
Awesome.
Beautiful.
Let's dive into research.
Okay.
Yeah. So maybe the first question would be, what made you get into research? And then latest projects. We were kind of going through some of your research this morning, but we can talk, maybe cherry pick some of your favorite things you're working on right now.
Sure. So what got me into research, and I practiced for 25 years before, I switched over to the research geek role. And what always bothered me about clinical practice was, I have a patient in front of me, right, and I think I know what would help them, but I'm not really sure. And then the patient would ask me, was this going to help? And I'd have to say, yeah, I think so, all right, because where was the evidence for what we do, right? I'm older than you guys, right? But when I graduated in 1982, there was no research evidence about anything we did. And it made me uneasy. I felt an ethical dilemma, right? I'm treating patients. Let's face it, in clinical practice without evidence, you're experimenting on your patients. That's what you're doing. And I felt really uneasy about that. Maybe I thought too much, right? It's like, we need some evidence for what we do. And so that was sort of the driving thing, this, the very inquiring mind. I want to know stuff. I like to try to figure things out. And so that led me into the clinical research world. Like, one of my first projects was this activator, really do the same thing that manual manipulation does. I'm not convinced it does. But where's the evidence for that? So I wanted to answer questions. We were talking about this before. With respect to neck pain and concussion, I always felt, there's some connection here between neck pain and concussion. That's one area I'd like to research. I like to know what that connection is rather than just making stuff up. So the uneasiness of clinical practice, and I remember, you guys have been through the Yonder route. I remember, Yonder was here in Pittsburgh when Craig Liebenson was running some courses, and I had dinner with him, and he talked about this uneasiness of clinical practice and never really knowing and what you do really works or not. And if you think about it too much, it can bother you.
And keep you up at night.
Can it?
Yeah. Oh gosh, yeah.
Right.
Yeah.
So I feel like now, doing these trials, at least in some small way, I'm adding to the knowledge base so that it will reduce some of that uneasiness for the people behind me.
What's the biggest problem in musculoskeletal or rehabilitation research right now? Like, what problem are you trying to solve?
So I've gone through this phase. I shouldn't say a phase. So I was really interested in doing clinical trials, right? Comparing different types of treatment for different conditions. So for example, I did a stenosis trial that we published. By the way, what put me on the map at the University of Pittsburgh, that stenosis trial was funded by PCORI, the Patient-Centered Outcomes Research Institute. So I got funded in the very first cycle of that, right? That was a 10-year, it's in its second 10 years now, but in year one of that first cycle, I got one of the first 25 grants in the United States, PCORI. I was the first person at the University of Pittsburgh to get a PCORI grant. So that made me a rock star here at Pittsburgh. Sure. That didn't hurt getting this chiropractic program started, right? So I'm going to go back to that, right? So the importance of research is not just that it makes Mike Schneider important at the University of Pittsburgh, but it brings credibility to the entire profession. And mark my words, someday when we write the history of this program at the University of Pittsburgh, it's because of my research activities that led to that program getting accepted. So that PCORI grant really set me apart. And what we did in there was compared a combination of some manual therapy and exercise with a group approach with usual medical care for patients with lumbar spinal stenosis. And we showed that individualized care does better than the other two. The other two do work as well. So I think that leads some clinical relevance to this approach. But when I talk to chiropractors and physical therapists, hey, as a result of publishing that paper, have you seen an uptick? No. Why? Because I'm starting to realize now this second phase of my career is that doing clinical trials and publishing them isn't enough. So I'm getting more interested in the implementation science area, which is that, to answer your question, what I think the biggest problem is, people aren't getting to physical therapists or chiropractors because the primary care physicians aren't sending them. Why aren't they sending them? The evidence, the clinical trial evidence is overwhelmingly in support, and their guidelines say to send their patients for non-pharmacological treatments, right? So the guidelines are saying it, the clinical evidence says it, why isn't it happening?
To speak for St. Louis, I don't know if you have the same issue in Pittsburgh, big hospital conglomerates. So like Mercy in St. Louis, they don't have chiropractors on staff, and so all they have is physical therapy. And so
they do, but not enough to cover the territory.
So then primary cares are getting
punished if they refer outside of the hospital system.
Yeah, but that doesn't explain this. We have the same situation here. So we have 100 physical therapy clinics, maybe more now, associated with our University of Pittsburgh Medical Center. UPMC has 100 physical therapy clinics. So when a patient walks into primary care here with back pain, guess what percentage of them see a physical therapist? In our system, less than 10%. Now, why is that? Explain that to me. That's in-house.
Wow.
They don't send them. The problem, to me, the toughest nut to crack is the primary care nut, right? That for some reason, primary care, and it's not, when I say primary care, that's primary care physicians, it's DOs, it's physician assistants, it's nurse practitioners, they all work in primary care, and they all are not referring their back pain patients to PT in-house, let alone chiropractors. And so figuring that out, implementation science is the science of finding barriers and facilitators to implementing known effective treatments.
But once they get there, then a ball is still being dropped, I feel. So on Sunday, we had a guy named Thomas Bird. He's a famous hip surgeon from in Nashville. And so we were talking about, so he's the expert in the world in femoral tabular impingement, labral repair, et cetera. So we said, in the next 10 to 20 years, what's this going to look like? And he said, honestly, he goes, the procedure is probably going to be about the same. What we're getting way better at is being able to determine who actually needs this surgery. Right now, arguably, maybe too many people are getting the surgery, trying to figure out like how to classify these people a little bit better. Don't you think, like, in the world of research, that's where it continues to head, of like being able to pick the people that are going to do better at MDT maybe in this time phrase, and then we would be transitioning them into maybe a DNS protocol or maybe like a traditional rehabilitation protocol? Like, do you see that as kind of being the future for the people that are purely in the trenches, not in the ivory towers here at University of Pittsburgh, to really allow research to truly guide what we're doing? And I say that because every day in our life, all of us scroll through our phones with research on Twitter and stuff like that. And you read a piece of research, but it doesn't change what you do a lot of times, because you look at it and you're like, yeah, this means nothing. Like this, for all the reasons we were saying before we turned on the mics here. So how does research do a better job of capturing that, do you think?
Well, so remember, there's different types of research. That's what we're talking about right now. So you're talking about this from, as you should, from a clinician perspective.
Right.
Right? So from the clinician perspective, it's like, what treatment works best for what type of patient? Right? That's really what your question is. And how could research guide that better?
Mm-hmm.
Right? And that would require a different type of design for clinical trials, which is what we were talking about.
Mm-hmm.
So if for example...
So that's what you did in your stenosis paper? Is that...
Right. So we said, okay, patients with mild to moderate lumbar spinal stenosis, we know they don't need surgery. So what are some of the different approaches that could be taken for them? Well, one is a medical approach, right, to treat them symptomatically with medication. Another would be, hey, you know what? We just need these people to move better, right? So we send them to silver sneakers classes. And then, no, maybe it's better to individualize the treatment, right, one-on-one. So we did all three. And all three were relatively effective, but that individual group did better. So what we need to now try to figure out is, well, what kind of person will do well in that group class?
Right.
Right? And what kind of patient won't do well in that group class but needs the individualized approach?
So what do you think, it's then you're working that stenotic patient through an algorithm? Let's just say the starting point is, okay, they did not have a directional preference. Okay, so then you're going into this genuine exercise group. Or what do you see that looking like?
For lumbar spinal stenosis?
Yeah.
Yeah. So I think, first of all, let's think of this. One of the standard treatments is epidural injection, right? A series of 3. Like, where did that come from? I mean, that's just, there's no evidence for that whatsoever. Right? There's no evidence for it. And if you think about it further, so a patient at rest with lumbar spinal stenosis has 0 pain at rest. They're sitting, they have no pain. Well, what is that, inflammatory pain? No, they have no pain. So by definition, it can't be inflammation. So why would an inflammatory chemical like a steroid be helpful in a person who has a non-inflammatory pain condition? So I think fundamentally what we have to understand is, when patients have a pain, what kind of pain is it? This idea of pain phenotyping is really important, right? Do they have acute pain? Do they have chronic pain? Is it nociceptive pain or is it neuropathic pain, right? Like, what kind of pain do they have? And with lumbar spinal stenosis, it's tricky because they typically don't get pain until they walk, and it's neurogenic claudication. So we don't even understand the mechanism of that.
Right. Do you think it's as simple, if we're trying to even determine who's in the chronic pain classification versus acute pain, or whatever you call it, is it as simple as giving them an outcome measurement to fill out, and that tells you which one of those 2 categories are in, or do you think there's more involved?
Well, I think we're going to quickly get into the difference between acute pain conditions and chronic. So by definition, lumbar spinal stenosis is a chronic condition and degenerative.
Yeah.
Right? So that's why, in my opinion, things like a mechanical diagnosis and therapy approach don't work as well, because that works better with an acute nociceptive type of patient.
100%. Yeah.
It works great for that kind of patient. Right? Acute disc protrusion with sciatica, man, that's the way to go, is directional preference. Lumbar spinal stenosis, maybe not. Because the chronic conditions, we have that biopsychosocial model. And when you deal with older patients who have fear of movement, for example, that fearful, anxious person, that has to be part of their treatment approach. Right?
But so in Annie O'Connor's research, they found that if we give them a yellow flag form, they score higher than a 55, then basically you have pretty good inkling they're in this category. Do you think it's that easy or not?
Well, let me backtrack for a second. So one of the trials that we published a couple of years ago was called the Target study. This is where we had 5 centers around the United States with patients that were acute back pain coming into primary care, right? So we have start back data, the start back tool, right, which is a risk stratification, puts people into low, medium, or high risk based on 5 psychological variables. So we had data on 5,283 patients. And that start back worked very, very well in predicting the course of care. So patients who came in who were low risk on the start back, about 20% of them were chronic at 6 months. Those who were medium risk, like 35% of them were chronic at 6 months. And high-risk patients, 50% were chronic at 6 months, regardless of what was done to them, whether they had PT, medicine, whatever. So that is huge validation for this model that psychological variables are one of the strongest predictors of prognosis, independent of anything else.
Right.
It's very, very strong. And so in the stenosis population, let's face it, if these people don't move, they're going to get worse. Let's not even talk about manual therapy for a moment, right? They got to do some kind of movement or exercise. We can argue about what the best type of exercise is, but they got to be moving. Well, if they're afraid to move, they aren't going to move. On the other hand, we found that there was more of a depressive, low motivation kind of patient, like give up. So they're not afraid to move, they just don't think it's going to help them. And they have to be motivated. And this is, I think, something that we take for granted in PT and Chiros, and why we have that module 1 of our PSP program, right? You got to understand these basic principles of motivating your patients or having them overcome fear. This is what all good coaches do with athletes, right? That model has to be brought into the clinic.
Right. Yeah, that's a huge, I mean, I always use examples of like Annie O'Connor, Stu McGill, name the name. Like they have intangible skills that are helping their patients get better that a lot of times they're not taking into account for. Like I saw with my own eyes with Stu McGill, where I did my preceptor, he was seeing some of the same patients that, I had seen with Clayton Skaggs. And what was fascinating was coming from him, I was just a Tri-9 student, I did the exact same thing with these patients, but he had a completely different outcome just because it was, the expert was in town, it was Stu McGill, he was coming with all this bravado. So that I feel like also isn't taken into account into the healing of people. Annie O'Connor is also another good example of just being great at that skill. I mean, she can basically will people better. So how do you reconcile that in the world of research?
Well, it would have to be taken into consideration. So another study that I was involved with was to develop some instruments, the PROMISE instruments. I don't know if you're familiar with those. These are, PROMISE is an NIH-funded study to develop, for example, generic versions of the Oswestry. So instead of having the Oswestry, which is a brand name disability index, there's a PROMISE physical function form that you can do. There's a pain intensity, a pain interference questionnaire. There's all these different questionnaires. And we looked into developing some new questionnaires that would look at what people used to call the placebo effect. Well, people don't use the placebo effect anymore. They use the term contextual factors of healing, or they use
What a rebrand there.
How about this? Non-specific effects.
Retread.
Yeah, non-specific. You got to add non-specific in there. That's how you know.
Right. So because like non-specific low back pain, which is ridiculous. But think of this for a moment. So we have this direct effect, which is the drug, and the placebo effect came from pharmaceutical research, right? So I got the drug, and I've got something that looks like the drug. So the specific effects are from the chemical, but when I give them this inert substance and they're getting better, those have to be non-specific factors, right? So the specific factor is the chemical, the non-specific factors is whatever else, and there's whatever else is a black box. But people have dissected that black box. So now we know there are some specific, non-specific factors, right? Treatment expectancy. Right? So when somebody sees somebody like Stu McGill or Annie O'Connor, the expectancy is that, wow, this person knows what they're doing, I'm going to get better. Mm-hmm. That's part of what used to be called the placebo effect. Sure. Doctor-patient relationship is another specific, non-specific factor. Right? People get along better, who like their doctor, they tend to get better. We know that the healing environment, when people go into a clean clinic, right? They've done research on this, right? People who go into a clean, bright, shiny new office do better than those who go into a basement clinic that looks, shabby and dirty.
Sure.
People judge that, and that's part of the healing effect. So all these factors have to be taken into consideration. Now try to run a research trial that looks at all these variables. Right?
Hard.
The clinician's psychology, the room that they're in, the patient's expectations, right? Are they depressed? Are they this? Are they that? I mean, there's so many factors. Do they have a directional preference? Yeah, that matters. I think the physical findings, let's not throw the bio out with the psychosocial bathwater. They all are mattered, and that's why it's so complicated to run trials that look at, these are all variables that have to be taken into consideration.
Is it as easy as just standardizing things? I mean, surely that can't be the simple. I mean, how do you take that into account?
Well, you have to study those. If you can't measure it, you can't study it.
Sure.
So can you measure treatment expectation? Yes. Right? Can you measure patient-provider relationship? Yeah. Can you measure depression, anxiety, fear of movement? Yeah. How many people are actually doing that in clinical trials? Mm-hmm. Very few.
Sure.
But let me get back to implementation science. I think we have a bigger problem. You're looking at this as a clinician. I'm looking at this from the ivory tower now, which I'm saying, like, why aren't patients with back pain even getting to you? Mm-hmm. That's a bigger problem, right? I mean, you're saying once I get them, what do? I want research to help me guide my treatment day to day. There's research that has to figure out why they aren't even getting to you.
Sure.
And that's implementation science research.
But think about how much of the profession is actually implementing a program that would even remotely look like PSP. So even if they are getting there, they're not getting...
Well, so let me follow this up. So in the implementation science world, we talk about barriers and facilitators to implementing a known effective treatment. So for example, we know that all the guidelines recommend non-pharmacological care for back pain. Right? So if I'm a patient with acute back pain, the guidelines say try PT or chiro. So why aren't primary care providers sending people? Why in our own system are less than 10% of the patients getting to PT? Well, we've interviewed primary care physicians, and guess what they say? Well, you know what? They're going to get better anyway. So this belief that back pain is going to get better no matter what you do, which is not true. In our trial, we showed even the low-risk patients, 20% are going to be chronic at 6 months. That's a lot of people. So this belief that back pain is going to get better no matter what you do. Number two, why don't you send them to physical therapy? They're right here. It's in-house. Well, I don't know what they're going to get. The wide variation, to your point, the primary care doc says, I'm not giving them a blanket PT referral because I don't know what they're going to get.
Right.
They go to PT A, they're going to get ultrasound. They go to PT B, they're going to get McKenzie. They go to PT C, they're going to get traction therapy. They go to PT D, they're going to get spinal stabilization exercises. I don't know what they're going to get. And since they're going to get better no matter what anyway, let me just see how this thing plays itself out.
Sure.
But variation of practice is the number one reason they don't refer to PT. And I would think it's the same with chiro.
Oh, 100%.
Right? They don't know what they're going to get.
Right.
Yeah.
Come full circle to the PSP program, right? That with our PSP program, we now have 4 of our physical therapy clinics. Those physical therapists that work there who've been through our PSP training, they've been designated as the program for spine health within our UPMC system. And the director of those is a PM&R doc who's very aligned with the PSP program. And that's how he's selling it to primary care. Hey, don't just send them anywhere. We've had this PSP trained physical therapist that will see these patients. Send them to one of my 4 clinics. And he's gaining traction with that. So he's getting more referrals. Now, once they're there, yes, are they going to get a more clinical reasoned approach to their care? Of course they are, because these are PTs that had done McKenzie training and our PSP training and other training that makes them much more in tune with the evidence. And they're going to get a more consistent care across those 4 clinics.
Well, especially in the world of orthopedics, I mean, if they have the right person who is vetting these patients out for them, it makes their life so easy, you know? So being able to determine, like, you're basically now become a surgical case, and being able to do that for the system is huge, because that solves the problem of people that are getting surgeries that they don't need, and you know, and I mean, that's what we see a lot of. We have a lot of unnecessary surgeries, but we don't. It's like the gatekeeper's wrong, you know.
Well, and that's what gets back to my comment about where the problem goes wrong is right at primary care, because at primary care, if somebody has back pain and they're not resolving in 4 weeks, rather than sending them to PT, they're sending them right to the surgeon.
Mm-hmm. And then the ortho's up to determine which direction.
And then the ortho kicks them back. So most of the patients in our system who get to PT have been primary care, either to PM&R or to ortho, then they get kicked back to PT. It should be the other way around, right? They should be going to PT first. PT should be determining whether they need to move on up the system.
Exactly.
It's a reversal, right? And chiropractic, by not being in these integrated settings, we're an afterthought, right? Chiropractors are an afterthought because they're not in the system. But PT being within the system and not being referred to is a great example that just being inside is not enough.
Sure.
Right.
Well, how about one of the slides that we pulled up is this treatment-based classification system. And so it sounds like this was somewhat of the idea of this triage. What someone in a primary care physician's office could do is to somewhat triage this patient and to determine where they should go next.
So we've just submitted an NIH grant in June that would involve, it's an implementation science grant. It's not a trial. Mm-hmm. And this would be this is our proposal. Our proposal is to have primary care clinics randomized into 2 groups. We're going to randomize the clinics. Right? It's called cluster randomization. And one group of primary care clinics, we're going to train their physician assistants in that treatment-based classification.
Yeah.
And basically, it's going to be very simple. We've created educational modules to teach them about back pain and just how, if it's non-specific back pain, right, and there's no neurological signs, send them to PT or chiro.
Sure.
Right, and if you are going to give medicine, we give them some training on the proper medications. The other group of clinics that are randomized, we don't do any training and just let them manage.
Okay.
And we want to see if the ones who are trained start sending more patients for non-pharmacological care. That's the trial.
Sure.
And guess what? We're not even going to measure if the patients get better or not.
Yeah.
And like, what? What kind of research is that? Because the research question is, can we facilitate more referrals to PT and chiro, which is more guideline adherent care?
Sure.
Right? So can we improve and remove the barrier to that process? Now, that's a very different kind of research, isn't it?
Very. Yeah.
And we don't even care what happens when they get there because we're making the assumption that they're better off in a PT or chiro's office than they are in that primary care office.
Sure. Sure.
How do you reconcile as a researcher, Mike, this concept of a kinetic chain? So people like Dr. Levitt, Gray Cook, Pablo Collage, there's these extreme experts in our field, in our world, who are basically promoting a model that's telling us that a lot of times you have to look outside the area of complaint to find out like where the true cause of the problem is. Pain, puts a wrinkle in all that. It's different than like if your watch stops working, we find the part that's broken, we fix it, and your watch works again. The human body is very complicated for all the factors that you mentioned before as far as chronic pain, but also that the cause of dysfunction can be away from the site of complaint. How do you reconcile that in research?
That's actually a very simple clinical trial that could be designed, and I've taken a lot of. As we talked about before, I've not gone over to Prague and studied the Prague school, but I know enough about it, and I took Yonder's courses and a couple of Pavel's and stuff like that. Their challenge is that they haven't done the research, the clinical trials. It'd be very simple. Take a group of patients, let's say with back pain, and randomize them to this kinetic chain approach or to some other approach. And you're going to see that my prediction would be that if somebody takes this kinetic chain approach, if you will, and looks outside...
Regional interdependence might be the term that, whatever you want to call it, but yeah, people are calling it different things.
Well, it would be a different approach to their treatment, wouldn't it? If you took this approach where you're going to look outside the spine...
Right.
Versus looking just at the spine.
Yeah, exactly.
Right? So you have a trial, you randomize people to those two approaches, and compare them. That's not difficult to do. Right? Somebody could do that. Why they haven't done that in the Czech Republic, I don't know. They should, because until they do, I tried to get them here to the University of Pittsburgh. Our PT department doesn't want non-evidence-based courses being taught. There's really no evidence for what they do, frankly. Right? There's no clinical trial evidence for that approach. That's the problem. But conceptually, it's just designing a trial to compare the two. And we've talked about this. So let's say you compare this, what do you want to call it?
Regional interdependence, kinetic chain.
Okay, we'll call that approach A.
Yeah.
Versus, what's approach B? McKenzie, let's say.
Yeah.
Or a directional preference exam. So people get randomized to these two groups. You look at their change in pain and function, let's say at 8 weeks. Well, and you find no difference between the groups. So does that mean there's no difference between them? No, because if you look at each of those groups, you would look at responders and non-responders. And I would predict that you'll have really great responders to each approach and really poor responders to both approach. And then you have to figure out why, right? Why is somebody who was randomized to the McKenzie approach, why did they do well? Why didn't they do well? Same thing with this regional interdependence. There's probably a certain type of patient that does better with that and a certain type of patient that doesn't do well with it. And that's where that research would have to go.
Right.
Right? And it can be done.
Sure. Cool.
Just nobody's doing it.
Right.
Yet.
Not yet.
And I mean, delineating too, like when I feel like in the world of research, it's always like, how's your pain? How's your pain? How's your pain? Like looking at more so like some functional goals, whether it's just like everyday activity or it's functional goals that you're looking at as a clinician.
Well, so my favorite's the patient-specific functional scale, right? You ask a patient what 3 things are affected most by your pain right now.
Yeah.
What 3 things you love to do that you can't do right now? And they tell you those 3, and you rate them on a 0 to 10 scale, each one of those. That could be the primary outcome measure.
Sure.
Mm-hmm.
Right? It doesn't have to be a numeric pain scale. Now, researchers don't like that patient-specific functional scale because not all patients are going to say the same 3 things.
Sure.
Oh, well, get over it.
And then some people shut their lifestyle down, so they're not doing it. They're going to put on the thing, well, I'd like to play golf again. Well, they're not playing golf anymore because they're afraid to hurt themselves or they've quit playing golf, so.
But to me, that would be a very individualized outcome measure,
right?
Rather than just using a standardized Oswestry or pain score.
Right.
Sure.
Okay.
Beautiful. We've got an hour already. We told you it was going to go by quick, didn't we? Okay. So, man, we hit just about everything. Give us your last final plug for coming to UPitt for the PSP program and where they can find more information about it.
Yeah, so I'll make a plug for 2 things. One is the chiropractic program. I don't have to make much plug for it because once we have a chiropractic degree offered at a major university in the United States, it's going to be a game changer, not just for the profession here, but worldwide. And I predict that the program getting started here at the University of Pittsburgh might be a domino effect where we have other major universities that will eventually follow suit, or some of the private chiropractic colleges may want to merge or partner up with major universities, but I think it's going to be a game changer. As far as the Primary Spine Practioner program, certificate program, it's open to both PTs and chiropractors. We've seen more uptake in the chiropractic world because, to me, it's just proof that chiropractors really want to do spine. I think we're seeing more physical therapists seeing the value of this PSP program as well, and we're going to continue to train both physical therapists and chiropractors, realizing that some people may take offense at that, right? That we're trying to train one profession over the other. We're not. We just feel that more spine care practitioners are necessary in the U.S., and that it serves a unique role in teaching both PTs and chiros how to blend a lot of things they're already doing into a better, more comprehensive package for spine care.
So we didn't actually get to answer that question. Do you see in the future that a chiro and PT are becoming the same person or not?
I do. It's already it's already happened,
right?
Isn't it? Yeah, it's already happened. And
so then, why would you even separate it then?
Well, here's another thing I think is wrong with healthcare, real quickly, is that we have these degrees and then we have these needs and they don't match up, right? Healthcare's changed so much where all these degrees that we have were created before the job descriptions. So the way I look at it is we have a job description for a non-pharmacological spine care person in healthcare. And it just so happens we have multiple degrees that fit that job description, right? That's where the problem is.
Right.
We'd have to blow up all the degrees and say, okay, what are the job descriptions that we need right now? And let's create new degrees that match up with those job descriptions. But we're trying to fit degrees into existing job descriptions in healthcare.
Yeah. Yeah.
It's a pretty good argument.
Yeah.
It's pretty good. I'll accept it. It's great.
Good.
Where can they find more information on PSP program?
Well, we have our website. It's www.pitt.psp.
Beautiful.
PITT.
We'll put it in the comments below. So
all right.
That's
good.
perfect. Mike, thanks for sitting down with us.
Yeah.
Thanks for showing us
job.
your
thank you.
Your
really
awesome,
appreciate it. Yeah.
Building here and continuing to push the profession forward and to push the research forward. We're appreciative of that, and we can't wait to keep reading your stuff. So
all right.
Beautiful. All right, guys. Have a great day. Stay tuned for the next one. I hope you enjoyed this episode of the Gestalt Education Show. If you liked it, share it, subscribe to it, send it to your friends, send it to someone that needs to hear this message. We really want everyone to be able to tune in and get the best clinical advice that they can, which we're hoping that we're giving to you with these special guests. So if you have any questions, please feel free to reach out to us, or if you have any suggestions on upcoming conversations, let us know. For a list of our upcoming courses, we're adding them all the dang time. So go to gestaltedu.com, click on courses, and they'll all be right there for you. All right, have a good day.